Hello everyone, a very good evening to all of you. I am Piyap of University Office. Welcome all of you to today's session. Our today's speaker is Mr. Vidya Prakash. You must have heard about him. He is one of our dynamic and versatile personality. You must have heard his lectures in various social media platforms like YouTube, different WhatsApp groups as well. Related to this lecture, if you have any kind of questions or comment, you can write in mention chat box or right side of your screen. Now, I would like to request our Educational Committee Chairman, Mr. Ashish Jain, to introduce today's speaker. Sir, it's over to you.
On this webinar session of CNMSD, today we have very distinguished speaker, Mr. Vidya Prakash. Just after passing this MRIT from RMCVARC, this result that is very difficult for anyone to publish. The name of this book is a guide for healthcare professionals and patients, and that was published in 2014. Then again he published another book, Emergency Preparedness Plan for Nuclear Medicine Facility. That was published as a Google book in September 2009. Along with that, he is founder of Nuclear Medicine Solutions. I must say this is a philanthropic work, a great philanthropic work by him. If you want to find out any kind of solutions related to nuclear medicine, be it regarding contamination, in any form related to nuclear medicine, visit his site, you will be able to get answer of all your questions. So he is versatile in all the areas, like you may get several lectures delivered by him, and which is hosted on YouTube, and that is where I personally always go and watch those videos, and I will recommend people also to go and watch those videos. That's really great. It will replace all your memories, and for beginners, it's great the scientific content what he is creating on this, and this is free of cost, available for all of us. Thank you, Divya. Having said that, I would like to call upon Divya to deliver his lecture. Today's lecture is on quality accreditation of nuclear medicine center or department, their need, and how to set up indicators. None other than you can be the better speaker on this subject. Over to you, Divya.
Thank you, sir. Thanks a lot. Thank you, Amit ji. Thank you, Ashish sir, for all these compliments. Hello, everyone. This is your own Divya Prakash. And today's topic we are going to discuss is quality accreditations of nuclear medicine centers or departments, their needs, and how to set up quality indicators. If someone is finding difficult to understand, let's make it a NABH accreditation of nuclear medicine centers or departments, their needs, and how to set up quality indicators. This is a quite different topic from routine which we generally see on webinars. Like yesterday we discussed interaction of radiation with matter. Sometime before we discussed QA of PET CT, and we discussed dosimetry of lutetium therapy patients. Those all are core subject topics, but this is a little different topic, but we all come across this all because nowadays all the hospitals or diagnostic centers are undergoing for NABH accreditation or JCI accreditations. So we all come across this problem because we are asked to make quality indicators, we are asked to make SOPs, we are asked to make policies, because these accreditation bodies, they have set so much of stringent standards. Those requires a lot of documentations. In hospitals there is a quality department, they help a little in preparing those documents, but again hardly someone knows anything about nuclear medicine, so we all are forced to make those documents. And in diagnostic centers this privilege is also not there, means there is no one who can help you. Then NABH consultants come in the picture, and they are so innocent guys, they don't know anything about nuclear medicine, and they give all the documents based on CT and MRI. So we will have to make our own documents, and then we go into this mode. What to do then? Because we do not know anything about all these documentations. So what are the infra related needs are there to undergo for NABH accreditation or JCI accreditation? Which are the policies or SOPs to be made? And how to quantify the quality? We know the quantification of images, we know the quality of images, but here we are going to quantify the quality. How that can be done? That of course we do not know. And what all the documents are required to be made for quality indicators? So in this presentation we are going to see the answer of all these questions, and we have divided our presentation in 4 parts, and we'll learn it from scratch. And we'll see what is quality in healthcare, what are accreditation organizations and their standards, and based on those standards, whatever they have laid down their policies, based on those standards, what are structural, procedural and outcome related needs, that we are going to see in 3rd part. And in the last part we are going to see quality indicators, where we will be seeing what are the documentations that needs to be done, and what are those quality indicators we can set it in our department. So let's begin and see what is quality in healthcare. There are a number of definitions of quality on internet, but for me, the quality in healthcare means achieving trust. How can we achieve that trust? By providing care and cure which is safe, effective, timely, efficient, equitable and people-centered. When we say safe, it should be minimizing risk and harms, including preventable injuries and reducing medical errors. Our services should be based on scientific knowledge and it should be evidence-based. There should not be any delay, and it should be maximizing resources use and avoids waste. It should be equitable, which does not differ according to personal characteristics such as gender, race, ethnicity, geographical location or socio-economic conditions. And it should be people-centered, means providing care with preferences and aspirations of individuals. So what are quality building blocks? There should be availability of beds, OPDs, staff, building, space, equipments, supplies, resources and basic monitoring of patients. During this COVID-19 pandemic, most of the governments from across the world had to put lockdown because all the structural related needs were not there in such a mass quantity. So they had to put lockdown to build this all so that they get the time and they build this all in a mass number so that they can handle so much of people together. When we have these all things like availability of beds and OPDs, then we need to have protocols, procedures, policies, training, efficiency, low waste and appropriate use of resources. So these all are procedural related needs we need to have, and then it comes outcome related needs. These all the things gives patient and staff satisfaction with low infection rates and good clinical outcome. That means the first building block is structure, second is process related, and the third is outcome related. In any accreditation or in any audit of quality, all the 3 things are checked or verified. So why do we need to have quality? There is a rising consumer expectations. Everyone who comes to the hospitals and they pay, so they need a highest standard of quality. So there is always a rising consumer expectation. There is a huge competition in the market. The Insurance Regulatory Authority, they have written that any hospital which is not NABH accredited or JCI accredited, the TPS cannot reimburse the money. There are consumer protection acts, there are regulations which say we need to give certain quality, and various government empanelments like CGHS, ECHS or ESI, they can be given only if the hospital is NABH or JCI accreditations. So in the second part, we are going to see what are the accreditation organizations and what are their standards. So let's see. There is a society called International Society for Quality in Healthcare, also called as ISQA. It is an umbrella organization which is responsible for accrediting accreditation bodies. Means they give accreditation to JCI or NABH like organizations. So they accredit to those who are responsible for accrediting hospitals or imaging centers or healthcare organizations. It was established in 1985 at Dublin, Ireland. It is a non-profit community and organization and dedicated to promote quality improvement in healthcare. It spans over 70 countries and 6 continents. This is the list of international healthcare accrediting organizations, and most of the major countries, they have their own accreditation organizations like Australia, Canada, France, Europe, Egypt, India, Malaysia. India has NABH, that is National Accreditation Board for Hospitals and Healthcare Providers. In Netherlands, New Zealand, Saudi Arabia, United Kingdom, United States and Turkey. In United States, there is a JCI, Joint Commission International. They give accreditation from across the world. So what are healthcare accreditations in India? As I have already said, it is a JCI, that is Joint Commission International. It is the NABH, and some organizations also undergo for ISO certifications, that is International Organization for Standardization. Let's see what is JCI. It is a non-profit organization based at Chicago, United States. It accredits healthcare organizations and programs. The international branch accredits medical services from across the world, and itself it is accredited by ISQA, and it is a prerequisite for international Medicaids or medical reimbursements. Whichever hospital which clientele base is international patients, they go for JCI accreditation, because international reimbursements or aids, they cannot be received if the hospital is not JCI accredited. JCI was founded in 1951 with the name Joint Commission on Accreditation of Hospitals, that is JCAH. In 1987, the name was changed as JACO, that is Joint Commission on Accreditation of Healthcare Organizations. In 1998, the Joint Commission International branch was formed as a division of Joint Commission Resources Inc. And in 2007, the name was simplified as the Joint Commission, and it was rebranded itself by changing name, logo and tagline. So let's see what is NABH. It was founded in 2005 to create accreditation program for healthcare organizations as constituent board of QCI, that is Quality Council of India. We'll see in the next slide what is QCI. In 2006, they issued their first edition of standards, and 2007 they created their first hospital in Kerala, and up to now they have accredited up to around 8,000 plus healthcare organizations. Their standards are accredited by ISQA, and it is focused on patient safety and quality of delivery of services. Let's see what is QCI. It is an autonomous body, self-sustaining, non-profit organization registered under Society Act and has its own MOA or rules. And these all are 5 constituents board members, that is NABCB, NABET. These all are associated with the different industry related certifications like education and training. It is a NABET. There is a National Board for Quality Promotion, NBQP. There is a NABH which accredit hospitals and healthcare organizations, and there is a NABL who accredits for laboratories. NABH accredits healthcare organizations from all the variety of, like they accredit hospitals, imaging services, blood banks, dental centers, Panchkarma clinics, eye centers, laboratories, and they have even issued their guidelines for best practice for patient safety by the medical devices. But we are not interested in these all the things, and we will focus on hospitals and medical imaging services. Just now they have issued their 5th edition of standards, which was released in April 2020, and this is the first time their core objective is patient safety, and the compliance with the patient safety is mandatory irrespective the organization is compliant with the other elements or not. And in December 2019 they issued their 2nd edition of accreditation standards for medical imaging services. On May 10, 2020 later, they have said that whichever organization will go for accreditation, their accreditation cycle will be for 4 years. Earlier it used to be of 3 years, and accordingly that period of reassessment and all they have defined. So what is the process of accreditation? We need to have all infra related needs like signages, hand grabs, fire exits, these all the things, and then we need to prepare the documents. And once all the things are ready, we need to submit an application, and there is one self-assessment toolkit which is self-declaration on their website which we need to fill and need to submit. And then once all these things are done, fees is paid, then the organization goes for pre-assessment, and whatever non-conformities are there, they are sorted out, and then the center or the hospital goes for final assessment. And after closing all the non-conformities, the hospital or the center is accredited for the NABH. And this is the 15 to 17 months they say for surveillance assessment, but once it is for 4 years, it is in the 20 to 24 months they will be taking for surveillance assessment, and then 6 months of the period will be remaining in assessment, then the reassessment takes place. In graphical representation, the first is pre-assessment, non-conformities closure, then the final assessment, and then it becomes NABH accreditation, and then surveillance audit, and then re-accreditation. So what are the NABH standards? NABH has set standards of 651 objective elements, and out of that 651, this 102 are from core category, and they are audited or they are checked on each occasion of surveillance or assessment. This 459 comes under commitment category, this 60 comes under achievement category, and this 30 comes under excellence category. This 459 are checked during final assessments, 60 are checked during surveillance assessment, and last 30 are checked during re-accreditations. So the NABH book has got 10 chapters, means they have divided their standards in 10 chapters, and the first chapter is access, assessment and continuity of care. Second is care of patients, management of medication, patients' rights and education, hospital infection control. Sixth chapter is patient safety and quality improvement. Seventh is responsibility of management, facility management and safety. Ninth is human resources management, and the 10th is information management system. Means nothing is left when we are making the documentations. For diagnostic centers, they have divided their chapters in 7 parts because there are a number of things which are applicable for the hospitals. They are not applicable in the standalone diagnostic centers. And they all are mostly same, only the second chapter is imaging procedures and interpretations. The rest all are almost same. This is the chapter 1, access, assessment and continuity of care, where the first point they say organization defines and displays the healthcare services that it provides. Means the scope of services should be displayed. Like that they have mentioned all their standards in chapter 2, chapter 3, chapter 4. These all the things, this document is available freely on internet, so anybody who wanted to refer, they can go and refer, see what all their summary of standards. So all these 10 chapters, they have mentioned their standards. And in the standards they have mentioned what are the core category, what are the commitment category. These are all the things mentioned clearly in that book. So let's see what structural, procedural and outcome related their requirements. When we go for any setup, the first thing is statutory compliances, which includes CMO registrations, registration under Shops and Commercial Establishment Act, PCB consent, that is Pollution Control Board consent to generate biomedical waste, MOU with biomedical waste collecting agency, PCB license for air pollution, license for water pollution, authorization for disposal of radioactive waste, fire NOC, PC and PNDT Act registration. In Delhi it is mandatory to have PC and PNDT Act registration. RSO should be there, and all our AERB licenses and approvals like PET-CT approval, high dose therapy approval, these all the approvals should be there in place. And if there is a pharmacy within the premises, the license for pharmacy should be there. And if there is a canteen inside the premises which sells food or tea or beverages, they need to have a license for that. If you are serving tea or anything which is you are not charging for that, you need not to have the license. But if you are charging for anything which is food related, then you need to have a license for that also. A statutory requirement is ambulance. You have ambulance, or you should have a MOU for the ambulance with any hospital or any organization. Once we have these all the things, these all the signages we need to put, and these all the signages should be having the details of facilities available. Facilities not available should also be mentioned on the board which is outside of the center of the hospital. Timing should be mentioned, and for inquiries, phone numbers, emails, website, these all the details should be there. The scope of services where we are displaying, and it should be bilingual, means Hindi or English if it is in the north, and if it is in the south or where the regional languages are more prominent, so it should be in that particular regional language also. We should be displaying mission and vision of the company. Patients' rights and responsibilities should be displayed in the premises, and it should be bilingual. This fall prevention posters should be there. Hand wash technique should be displayed in all the washrooms. Of course, these all are radiation symbols of if you are breastfeeding your child. This caution symbols for pregnancy and breastfeeding should also be there. This emergency procedure of minor spillage and major spillage, it should be displayed. These are all radioactive symbols or the CT machine symbols, it should be there. And this copy of license should be pasted outside the CT room or the PET-CT room. The toilet should be having this grab bar, so that many patients, they are not able to get up by their own, so this grab bars should be there. This emergency call bell should be there in all the washrooms, so that if patient falls, they are able to call somebody by pressing those bells. And toilet should be wheelchair enabled, means if the patient is wheelchair bound, then they can use the toilets. This silence zone and no smoking boards to be there. And very important, this fire signages. These fire signages are very important and checked very strictly. Just few days back we have seen an accident in Gujarat where many patients died because of the fire in the hospital. So all the authorities are very strict about the fire signages, and all the fire extinguishers should be having self-illuminating boards, so that if there is no power supply, there is complete darkness, these all the things will be seen. Staircases should be having this non-skid tapes pasted on that, so that patients should not fall, and it should be self-illuminating, because in the case of fire all the power generally it is switched off, so they can see where is the way and they can come out. This push bar should be there, and exit signs, this all are should be self-illuminating, and this fire escape plan should be there in all the rooms, so that if the patient is trying to run away, they find the way where to go. So let's see what all the documents are required for accreditation programs. There are number of documents are required, like Apex manual, safety manual, and infection control manual. This is the broad category, and And then let's see what is the contents of Apex manual. It should have introduction to organization and organogram, mission, vision, aim and quality policy. Quality objectives and list of committees should be mentioned in this. And all the chapter wise documentation like control of services, control of processes and procedures, control of environment, control of personnel, control of documents and records, risk control and safety, these all the documents should be mentioned in the Apex manual. And there should be continuous quality improvement programs for verification of processes and validations. Adverse event reporting and quality indicators monitor, these all to be mentioned in the Apex manual. And then the performance quality indicators, and at least one quality indicator should be related to patient services and one for each modality. Let's see what are the contents of safety manual. It should have introduction to center. All the medical codes like code blue, code red, these all should be mentioned in that. Safety committee, fire safety, electrical safety, radiation safety, electrical safety, medical gas safety, water safety, building safety, patient safety, vulnerable patient safety, geriatric patient safety, anesthesia safety, falls and fall reduction program, employee safety, personal protective equipments, risk management and sentinel events. Means nothing is left. Everything has to be documented and followed. Let's see what are the contents of infection control manual. It should have infection control program, goals and objective of MIS of infection control program, infection control committee, infection control team, their responsibilities, hand hygiene procedures which relates to personal hygiene, injection, oxygen administration, etc. Then equipment related protocols, environment related protocols of high risk areas, water quality, pest control, employee related protocols which includes employee health program, post exposure prophylaxis, surveillance and reporting of infections, and finally the biomedical waste management program. And these are all the documents which I have made, and I don't know whether you will believe or not, it took 2 years for me to make. Like Apex manual, control of services, risk control and safety. These are all the documents has been made. Radiation emergency programs, radiation safety, and then the SOPs, standard operating procedures. The contents of this, all the things are mentioned in my website and on the consultancy page, and the contents I have mentioned there in all the documents, and some few parts of these documents are there on the website. So anyone who wanted to see, they can visit the website and they can see. Let's see the last part of the presentation, which is how to set up quality indicators. Quality indicators are measurements of quality program. They are standardized, evidence-based tools to track clinical performances and outcomes. It uses readily available administrative data to help decision makers to call for action. It allows to track the quality changes over time and are backbone of quality assurance program. These few examples are there. You can make it of your own, and the examples are turnaround time. You can monitor for the startup procedure, means when the patient came, reported to, and the time when you started his procedure or her procedure. So that time monitoring means any patient who comes for the treatment or any investigation, they wanted their work to be done at priority. So how much time we are taking to start the procedure, that we can see in this indicator. And we can set the formula of total waiting time of all the patients from time to reporting to start a procedure divided by total number of patients whose waiting time has been taken into 100. And it can be made as system generated, means when the patient is coming, that can be entered in a system, and when the time is starting, when the test is starting, that can, all this can be system based, and results can be taken. Communication of critical results to referring physicians. There are some diseases which, like pulmonary embolism, GI bleed studies, HIDA, bile leak in liver transplant cases, testicular torsions, renal transplant rejections, and sometimes mechanical diverticulum. These all the cases, they require to be informed to the referring physician immediately. So that we can set as a quality indicator that within this much of time we are going to inform to the referring physician. And if someone is going out of that, so that we wanted to keep it within the time frame. And the best one which I like is the patient satisfaction scores. Means when the patient has availed the services and then we are taking the feedback, and feedback is taken in the scores of 5, 4, 3, 2, 1, and whatever those numbers they give, that can be given with some weightage, and it can be calculated. A score can be set for the threshold and something as a target. Means this much of score we wanted to achieve, and below this there is something troubling. So this we wanted to keep it within the range, so we will change our policies according to that. This can be calculated by sum of scores given by patients into numerical values on a scale divided by scores given by patients into 100. There is another quality indicator as a maintenance of radiation survey levels within permissible limit. We can calculate the TAT for reporting time. It means once the test is completed, we can keep monitoring how much time we are taking to give report to the patient. We can do number of reporting errors per 1000 investigations. We can also monitor number of contrast reactions per 1000 patients. Patient fall rate per 1000 patients can be monitored. Percentage of misadministrations we can take. Needle stick injury rate, which the number of needle stick injuries reported divided by total patients days in that period into 1000. The percentage of medical errors due to wrong identification of patients. Percentage of re-scans can be seen, and the employee satisfaction index. This also all this comes at the last point. And the index can be calculated for different categories of employees. So these are all the quality indicators we can make it on our department. Let's see what all the documents do we need to have for these quality indicators. We need to make an SOP for this. That SOP will have a purpose, scope, process, and how those calculations can be ascertained. This is the example of SOP of quality indicator for critical diagnostic scan report within the 15 minutes. We have said that within the 15 minutes we are going to inform to the referring physicians once the test is completed. And if we are not able to do that, our quality indicator falls. This measure information form we need to make, which will have working formula, data collection methodology, units of measure, sample sizes, frequency of data reporting, targets, staff communication methodology. These are all the things, and rationale of this quality indicator. These all the things should be mentioned in this measure information form. And then it should have an action plan to improve, where we should be having a plan for improvement of this quality indicator. There should be quality improvement priority grid, means which all the things we wanted to do first in this quality indicator, and based on those things we can give an score. And if the score is above 18, it is a top priority. If the score is below 14 to 18, it is a moderate priority. Based on these, all priorities can be set according to the quality indicator. These are all the things we'll have to prepare for the quality indicators. And then we need to set some target value and a threshold value of quality indicator also. So we have set a target of 100%, like we are going to inform to the referring physician within 15 minutes in 100% cases, and threshold value in 95% cases we are going to inform. Below that we should not fall. And then we should have data collection form, which should have a mention of patient name, age, sex, UHID, means the ID of the patient, name of the investigation, date, referring consultant, critical finding, investigation conducted by, time of obtaining result, critical findings conveyed to, means to whom we conveyed that finding, and at what time did we inform, and the person who informed. This all the details should be mentioned in this form, and we need to have it for all the patients, and then the final signature and the date. And then this is the data collection sheet, which will have a record. This is the data analysis of just an example. It is for the patient satisfaction score. This is the data where we set our target to have within 4.9 star to 4.6, and this is the data which is fluctuating. Like in January 2019 it was 4.8. In Feb it fell down a little, and then it again improved, then again it fell. Here the management need to think why the quality is falling, and then management took some action, then the quality improvement took place. This is the mean of our data, and this is the upper control limit, this red one, and this green one is the lower control limit. These all are mean plus 2 SD and mean minus 2 SD standard deviations. So our data should be fluctuating in between mean plus 2 SD or mean minus 2 SD, then we are following a good quality indicator. Once we have done all these things, then we need to fill this self-assessment toolkit, which will have all the declarations, like with the chapter wise. This is the very long 18 pages document, and they ask for whether documents is there, yes or not, and once the document is there, whether implementation is there or not, and based on those things we need to self give this scores of 0, 5, 10. Means if the documentation is there, then it is a 5 marks and it is not implemented. If both the things are there, then the marks is 10, and if nothing is there, then we are 0. So this is the self declaration for all the points, like roles of responsibilities of each area of service delivery are defined. Medical imaging services ensures justification of referral according to patient conditions and urgency of diagnostic and radiation risk. These all the things they have mentioned, and then finally we need to submit this on the website. This is the page 2, and like this there are 18 pages. Finally, once we undergo through all this process of application submission, pre-assessment, non-conformities, closure of all pre-assessment and final assessment, then this certificate is awarded to us, which is signed by NABH CEO. Thank you very much. If any queries or if there is anything, please feel free to write us at support@nuclearmedicinesolutions.in. And also you are free to ask questions right now. Thank you very much. Thank you, Amit ji. I have finished my presentation, and audience are free to ask the questions.
Hello. We have few questions, Divya.
Okay, sir.
As we have Dr. Pankaj Tandon also.
Okay.
So that,
Okay. I cannot answer his questions. He is NABH assessor. Yeah.
He has been regulating us for last so many decades. Principal assessor of NABH also.
Yes. That is the answer.
Unmuted. I would like to keep him unmuted so that he can answer few of the questions.
Okay.
So he is very knowledgeable in this.
Okay.
Question is from Indra Madam Parades. She is asking that is the requirement of staff toilet mandatory for nuclear department? Yes.
NABH is not only concerned about the patients, but they are very much concerned about the staff also. They say for the lockers should be there for staff, the restrooms should be there for the staff. So this is the basic requirement. This is not only for the nuclear medicine. This is for all the healthcare organizations. They should have a separate for staff. These all the toilets, means the place where they can have food. These all the things should be there.
Okay. Second question from her only. Can the frequency of extravasation be considered as quality?
Yes, definitely. This can also be made. Means whatever I have shown, these are only examples. Number of other quality indicators can also be added into that list. But we need to prepare the documents for all the quality indicators, and we need to monitor those quality indicators.
Okay, thank you. So next question is from Vidhi. What are the documents regarding radiation safety required by NM Center?
This radiation safety manual should be there, and emergency preparedness plan. See, NABH, they know that regarding radiation safety, AARB is very strict. So they do not much bother about the radiation safety, because they know that AARB looks after about that. So NABH mainly they look for patient safety related things or the staff safety related things. But of course they see these documents, and there was a NC for radiation safety manual was not there in my center, so I had to prepare that radiation safety manual also. They see these documents.
Yeah.
Ashish, if you permit me, can I add one thing?
Yes, sir.
What rightly has been asked by Riddhi has asked, and Divya has really given a very nice answer. But personal monitoring records are one of the most important records which NABH assessor sees in that.
Yes, sir. Very true.
Whatever the TAD readings you are getting it, and whether the same has been disseminated to the employees or not, that is one of the most important things they used to see it, apart from the other radiation safety measures which Mr. Dilja has already indicated.
Okay, thank you, sir. Another question is from Dr. D.A. Raju Babu. How practical is it to implement quality indicators in actual practice?
It is difficult. Truly, if you see, because these days there is so much of workload is there in the departments and all the kind of healthcare centers that monitoring of these kind of things is very difficult in all the times. We actually follow all these things, but we do not record. So when the assessor comes, they find these records are not there. But we have to prepare.
Okay, thank you. I must say that.
Ashish, can I add a point?
Sure, sir. Sure.
Ashish,
Yes, sir.
Divya has really told in a very nice way that definitely so many indicators are there, but the most important indicator which assessor sees is turnaround time. Second is the patient satisfaction, referral analysis, how the doctors are referring and how they are taking care of. Staff is one of the important things which generally imaging centers not bothered about it. Staff satisfaction one by most. So there are many indicators, sub-indicators are there, but if you can able to show the first 5 important indicators like turnaround time, patient satisfaction, referral, how the doctors have been referring the cases and whether an analysis has been done, the feedback and complaints, and important thing is the staff is satisfied or not.
Dr. Tandon, may I speak?
Yes, sir, please.
Yeah. Now, if that is the case, why don't you put in a gradual manner? These are the essential things, these are the requirements, these are the other. See, graded manner, if they are there, then it will be easier. Otherwise, if you go on writing the data of each patient, it takes nearly so much time for only writing the data itself.
It's not a data, sir. Basically, all imaging center used to make a forms, and on a sample basis, they have to collect the forms and they have to find out the scores given and they have to do the analysis for that. It is not for each and every patient, but on a sample basis, they have to take this particular data. What actually the two slides, Divya has very elaborately covered all the indicators, and that all the indicators are very important. If you have more number of indicators, that means you are taking care of the center in a very well manner. But in a gradual way,
sample size.
Sample size usually, like I can tell you, this is one of the important things which I am telling you. Apart from that, when you talk about the films, what you are doing it, and you have to get, it is so difficult to get the feedbacks from the patient, from the referral, and practically center has to run to get those feedbacks, because in a place like Delhi, which Divya is referring, it is really difficult, but NABH assessor sees that you are really putting some efforts to get those samples and we are looking into it. It is not only the paperwork, it is only the quality. The more the quality you want to maintain, it is really you are taking care of the quality of the whole center.
If that is the case, why the sample size is not mentioned in the document?
See, we cannot mention the sample size in a standard because it totally depends on, usually the NABH assessors, when they go, they know it about 20% if the sample size is there, because suppose if I tell 20% should be, but it's not a mandatory thing. Only thing is they want to see to it whether centers who have been accredited or who are going for accreditation, whether really they're putting the efforts for the quality or not.
Thank you, sir. Thank you. We will move to the next question. The next question is from Mr. Raman. He wants to know that whether radio pharmacy of the nuclear medicine department comes under NABH or NABL categories.
I could not get you. Means the radio pharmacy center should be NABH or NABL? Is it the question?
Yeah, if it is nuclear medicine department, so it should come under NABH accreditation or NABL accreditation.
Nuclear medicine centers, as of now, they are NABH accredited. But I heard it some time back with the Pankaj sir itself that these imaging centers are going to be NABL accredited in future. But as of now, they are NABH accredited. But Pankaj sir will be able to tell because he used to go for the meetings of those NABH.
Ashi, basically what exactly happened, NABH and NABL both are the board under Quality Council of India. And the question which is pertinent to ask is whether radio pharmacy is going to come under NABL or NABH. Right now, if a person goes from NABH side, they look from radio pharmacy data also, but for radio pharmacy, nuclear medicine, NABL is coming out with a document and they are also told to take over. But still, the dialogue is a policy decision in the Quality Council of India whether who has to do it. Right now, both bodies are ready. NABH has done many centers. NABL is coming up. They have also prepared their documents. But NABL is right now concentrating only those labs which are pathology labs, which are NABL accredited, and they also have imaging centers with them, like X-ray, CT scan, MRI. So they also take. But at present, they have not yet started it. Right now, NABH is only doing it, but both bodies are ready.
Okay, thank you, sir. Thank you. Next question is from Dr. Subhanand Bhushan. I think his question is already answered. He wanted to know that the standalone PET CT center comes under which category?
Okay. In NABH also.
Yeah. Next question is from Amit Naudiyal. He asks that validation of report or results, is it also an important indicator?
Yes. And one thing is very important, we need to have a peer review. Means the reports which are reported by our physicians, they should be reviewed by some other center also which is already NABH accredited. So reports, and both the reports are compared, means any changes are there, that should be notified and documented. And there should be internal verification also of the reports in some frequency of like 6 months. Like we do internal verification of reports, means blind reporting of the same patient by the two different nuclear medicine physicians, and then they are compared, and any changes which are something like fatty liver, this is a minor change which one see or the other person does not see. This can be omitted, and if there is some major changes, then there is a discordance and it goes for the peer review person who will be again blindly reporting from the other center or the other hospital. So these things are should be there.
Yeah, thank you, Divya. I believe we have another principal assessor of NABL, Dr. Anshu Sharma is here. Anshu sir, are you there? Hello. He is asking that what about sexual harassment committed in the center?
There should be a committee which is called as a anti-sexual harassment committee, which looks after about all these complaints of the organization. Means whatever the complaint is there, they goes to that committee and they take actions based on those complaints and whatever the investigations they undertake.
Apart from that, actually, apart from this committee, the assessor would like to see at least the females, whether the post training has been given to them or not.
Yes, they call randomly one or two female staff, and they ask, they are aware about who all are their members in the anti-sexual harassment committee, and the mandatory thing is there should be a female member in that and one external member who is not from the organization. They are also mandatory. Means they will give impartial decisions on their findings.
That Anshu sir is right. The diagnostic center comes under NABH, hospital radio pharmacy under NABH. The peer review of report have been removed as per the current MIS secondary decision.
Peer review has been.
Are you there? Can you unmute yourself?
It has been removed, sir. I am not aware because
current MIS secondary decision.
Because my center is going for surveillance assessment, and they have asked for the peer review, and this is just around 1 month back. Sir,
can I speak?
Yes, sir, please.
Actually, the peer review was existing in before NABH editions.
Okay.
And now in the current NABH MIS 2 second edition, this has been removed.
Okay.
There is no need for any intra-departmental peer review or inter-hospital peer reviews. That was existing before, you are right. But I think this is a new update which is coming in the second edition of medical imaging system, that you don't need to review of the report of the experts who has written the report, and there is no review because there are a lot of bias in the inter-observer variability. Even the same department, one finding, two consultants cannot different point of view, but that cannot be a correct or incorrect report. That is a difference of opinion, just like a rule or law. Two advocates have a different interpretation. The same way, the peer review has been removed from the MIS second edition. This is the current status I'm talking about.
Okay. Thank you very much for sir for.
Divya, what you are saying is because for a surveillance point of view, those already accredited with the previous edition, in the surveillance they are going to take care of it. But those labs, what Dr. Anshu is rightly saying it, because this particular edition has recently come, and those labs which are newly coming up, they have to adopt this particular edition. Since you are under surveillance, so definitely they will ask for that also.
Okay. Thank you very much, sir. Thank you.
And next question is from Amit Nautiyal. What about protocol validation?
It has to be there, and that is to be periodic. Means once in a 6 month or once in a year, protocol should be verified or validated, and it should be documented also.
May I tell something?
Yes, please.
Yeah, sorry for interruption. Actually, my question is about protocol validation means you see the protocols from one department to another, you will see a lot of distinction. Like acquisition wise, you can say if you see the international guidelines, for example, in case of grenogram, many centers are there like who are taking grenogram study line within 10 minutes. Few are there who are taking in 15 minutes. Many are there who are finishing 30 minutes. Few are there who are taking for 45 minutes. So there should be, I think, some kind of guidelines should be there, proper guidelines, which must be assessed by the NABH or assessors, or there should be some kind of protocol for them.
Amitji, this protocol things you are free to write in your protocol book. Whatever physician wants to write, they are free to write in their protocol. They are not seen by the NABH assessor of which protocol 30 minutes you are following or 15 minutes you are following. But whatever you are following, that should be seen in the practice. So this is what they wanted, and this standardization is the job of their SNM procedure guidelines. This is their job. NABH does not actually assesses for this. You are following 15 minutes or 30 minutes. You can take it for 15 minutes, and in the next year, whenever you are going to review the document, you can change it whatever you want. It means when the doctor changes, he needs something else. So this is why periodic review of all the documents are mandatory in this NABH assessment. And this periodic can be annual or half yearly, whatever you say.
Amit, the basic principle of this assessment is accreditation is whatever you are documented, that should be implemented. And that we are saying if you return the protocol, you document it. Assessor would like to see whether you are implementing the same thing or not, or whether you are implementing the same and documented or not.
Yes.
Okay, thank you.
All right.
Next question is from Sneha. She is asking, Quantum still has a review of the report as been required. Okay, she wants to inform that. So Quantum is different agency on it. Then is there requirement for internal audit team? Yes. Who all constitute it?
Yes, this internal auditing is again a periodic requirement. Whatever you are writing in your manuals, an internal audit has to be there. And regarding the members, this again depends upon the organization. Whoever they wanted to keep their members list, they can keep. I think this would be based on who all are related to basically those kind of things. They can be members or the president or the secretary of that committee.
So another question is, what are the categories for internal audit? Is it same as NABH audit?
Categories means, see, stocks you are monitoring, how much it is coming in, how much coming out. The record keepings you are maintaining, all the forms, all the consent forms, they are being filled properly. All the things are audited internally. Means we have set the policy as a managing director or as a CEO of the organization. You have appointed some quality manager who has issued the documents, and based on those documents, some individuals follow that procedures. Means the reception staff should take, or means whoever is responsible for taking consents, they should take proper signatures. They should inform proper procedures. These things are to be documented. These things are checked in internal verifications. These protocols, all the things are, means whatever procedures, whatever laid down you have set in your manuals, these are monitored or audited internally. this should be done periodically.
Okay, thank you, Divya. And I think we are exhausted with all the questions. And if it is possible, I would like to give some concluding remark by Dr. Pankaj Ranjan and Dr. Ashish sir. They want to conclude something out of this.
First of all, thanks Ashish, Mr. Ashish and Mr. Amit that who has given me an opportunity to intervene and then cleared some doubts. No doubt Mr. Divya has very excellently prepared the particular slides and the way he has spoken on that subject, which is of interesting subject of those who are coming up. And definitely we all know the work what Divya has done it till date without any interest and all. He has very nicely presented all things, and if at all you go to any consultant for such kind of work, they definitely charge a huge amount of money. But Divya has made it very easy for those, and those who have heard about this particular talk is very useful for them. Thank you, Divya, for such a wonderful talk you have given.
Thank you very much, sir.
Ashish,
Thank you very much, sir.
for bringing such a nice talk on the CNMST also.
Anshu sir, are you there?
Hello, sir. Yeah, Ashish sir.
Yeah,
I think I think it was an excellent presentation. I have commented 3 times. Divya, it is very nice to hear Divya all the time. It's a very good presentation. He works very hard. He does his presentation of doing thorough research. And as I go with Dr. Pankaj Tandon that the presentation was excellent. And those people who are doing NABH, they know how much hard work it has to go through these NABH processes, which Divya Prakash is nicely displayed. And we must congratulate Divya Prakash and thank him for sparing and teaching all of us on this difficult topic. Thank you, Divya.
Thank you very much, sir. Thanks for all the compliments. Thank you very much, sir.
Thank you. Great.
Thank you, Divya. Thank you, all the listeners. Over to Amit.
Thank you, sir. Ashish sir. Thank you, Kandam sir. Thank you also, sir, for your concluding remarks. Once again, thank you, Divya, for answering all the questions very patiently and comprehensively.
Thank you, Amit ji.
Thank you, all of you.